welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breitster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we will be taking your questions throughout the hour by phone. The toll-free number is 1-800-452-0662, or you may send your written questions by fax. The fax number is 518-426-0696. We will also be taking questions by email. Please email us throughout the hour at any time at phlive.ny@gmail.com. Today's program is Breaking the Fall, Community Injury Prevention Strategies for Older Adults. Our guests are Dr. Mary Gallant, a professor of health policy, management, and behavior at the University at Albany, and Dr. Jane Corrarino, who works for Suffolk County Department of Health Services. Thank you both so much for being here.
Thank you. It's a pleasure to be here.
Welcome. So Mary, let's start with you. Of all the different topics that we have and things we could talk about, why are we talking about falls prevention?
Well, falls, one of those topics that we often don't hear too much about, but falls are really a very common and significant problem. We know about a third of all older adults, people over the age of 65, fall every year. And falls are the leading cause of injury, injury-related hospitalization, and the leading cause of injury-related deaths among older adults. So for example, in 2010, falls among older adults accounted for almost 2.5 million emergency department visits, over 650,000 hospitalizations, and more than 20,000 deaths.
Wow, those are some pretty staggering numbers. It seems that falls are occurring pretty frequently in older adults.
You're absolutely right. So to give you an example, on average, every 15 seconds in this country, an older adult gets treated in an emergency department for a fall. And on average, about every 29 minutes, an older adult dies from a fall. And the economics of the falls problem are pretty significant as well. So in 2010, falls accounted for about $30 billion in direct medical costs. And unfortunately, these numbers represent only the tip of the iceberg. We know that many more falls occur that don't require medical treatment, but that still lead to serious consequences for older people.
Well, let's talk about those consequences. You've told us a little bit about the numbers and how many people are falling. What are some of the consequences of those falls?
Well, there's a wide variety of negative consequences that can occur from falls, including consequences for mobility, independence, and physical and mental health. So a fracture, a broken bone, is a common consequence. Some of the most common fractures that occur from falls include hip fractures, fractures of the arm or wrist, or broken ankles. Head trauma is another common outcome from falls, and in fact, falls are the most common cause of traumatic brain injury among older adults. Another different consequence is fear of falling. Which fear of falling is quite a common fear among older adults, but particularly for someone who has fallen, it can lead to pretty significant fear of falling, which has pretty major quality of life implications and can actually increase one's risk for future falls. We'll talk about that in a minute. And falls are often thought to be kind of a sentinel event for many healthy or otherwise active older people. Once they experience a fall, it can be sort of the beginning of a pretty major decline in health.
Wow, so obviously falls are happening pretty frequently. There's some pretty serious consequences associated with falling. Mm-hmm. So what do we know about fall prevention and stopping this from happening before it even starts?
Yeah, well, the good news is we actually know quite a lot about falls and how to prevent them. So first of all, we know that falls are not a normal part of aging, even though that's a pretty common belief among a lot of people, but falls really aren't an inevitable part of aging, and they're not normal. They can be prevented. And falls, we know that falls have known risk factors and causes. There's good evidence for what those risk factors are. And there's also a good evidence base about what works to prevent falls. But the bad news in this situation is that these effective fall prevention strategies and programs really haven't been as widely implemented as they need to be to have an impact on this problem.
Okay. So can you talk to us about some of the different risk factors for older adults?
Sure. preventing falls is a kind of a complex problem because there's so many different, different kinds of risk factors. And I should say that today we're talking just about falls that happen in non-institutional settings. So falls that occur in institutions such as hospitals or nursing homes have kind of a different set of risk factors. But we can categorize most of the major risk factors for falls into two broad categories: personal risk factors, which have to do with characteristics of a person or an individual, and environmental risk factors, which have to do with characteristics of the home environment or the built or outdoor environment. And oftentimes these risk factors work together so that someone who has some personal risk factors would then become more susceptible to environmental risk factors as well.
So let's look at, we showed that chart on the screen, and you said there's a number of different categories we can break them down into.
Right.
One of the things on that chart said non-modifiable risk factors. Can you talk to us about what some of those are and what those look like?
Sure. So by non-modifiable risk factors, we're talking about things that really can't be changed. So age, gender, and race fall into this category. So fall risk is age-related. So the fall risk and risk of being injured in a fall does increase with age. There are some gender-related aspects to falls. So older women are more likely to fall and more likely to be injured in a fall, but older men are more likely to die from a fall. And then we also know that fall rates are highest among white older adults. And another non-modifiable risk factor is a history of falls. Someone who has already fallen is significantly more likely to fall again in the future.
Okay. And so on the other hand, then, there are some risk factors that can be modified. Can you talk to us a little bit about what are those modifiable risk factors?
Sure. There's actually a lot of potentially modifiable risk factors, which means there's a lot of points for prevention to help address this problem. So two of the major modifiable risk factors are lower body weakness, or weakness in like the major muscles of the leg, and problems with gait and balance impairment. Sleep disturbances also are a risk factor for falls, as is taking multiple medications, particularly taking 4 or more medications or any type of psychoactive medication. Fear of falling, which we've mentioned before, is also a risk factor. Many people who have a fear of falling end up reducing their activity, engaging in more sedentary behavior because they're afraid of falling, but in the long run, this activity reduction ends up leading to more, weakness in muscle weakness and more balance impairment, and as a result increases one's risk for falls.
Interesting. And are there other modifiable risk factors as well?
Yes, evidence indicates that using a walker or cane is a risk factor for falls, oftentimes because those assistive devices may not be used properly, and so they actually raise the risk of falling. Not surprisingly, vision impairment is an important risk factor for falls. And most of the chronic diseases and conditions that are common among older adults also raise one's risk for falls. And so this includes things like diabetes and arthritis, osteoporosis, Alzheimer's disease, having had a stroke, and incontinence, for example.
So there's a lot of different risk factors that actually are modifiable, so that seems like good news. I mean, there's things you can do. There's risk factors, but there's something we can do about it.
That's absolutely right.
Excellent.
They can be changed.
Great.
Right.
So what about some of the risk factors that exist within one's home?
Yeah, it's the fact that the majority of fall injuries occur inside the home, and that's not because our homes are the most dangerous places we are, but it's because most of us spend most of our time inside the home. And it's thought that the home environment itself, or aspects of the home environment, are thought to play a role in about 30 to 40% of falls. And most commonly, falls in the home occur just when someone is, walking on a level surface but falls or trips or slips. The second most common type of fall to occur in the home is when someone is transferring, getting up out of bed or a chair, for example. And it's also common to experience falls on stairs or steps. One of the things about our housing is John Pinus, who's a very well-known falls researcher at the University of Southern California, has used the phrase Peter Pan housing to refer to most of the houses in which we live, and that is that they're designed as if we'll never grow old. In other words, the typical house has many features or characteristics that kind of pose hazards, especially when combined with some of the impairments that might go along with aging.
Interesting. That's an interesting term.
Yeah,
and certainly we don't always think in advance, and this thing that seems like such a great feature now, how feasible is it going to be to maneuver this in our older age?
That's right, yeah.
So what are some of the more common areas, the more common problem areas that are within the home?
Well, just as one might expect, 3 of the most common problem areas include outside steps, inside stairs, especially when stairs, are commonly used as a dropping off place for, clutter, and bathrooms, which are often unsafe just because of they have slippery and hard surfaces and are hard to access sometimes.
Okay. And what are some of the common home hazards that contribute to falls, in addition to the clutter on the stairs that I know I'm guilty of?
Yeah, me too.
What are some of the other hazards that contribute to folks falling in the home?
Well, unfortunately, there's many common aspects of a typical home environment that can contribute to falls, and these include things like clutter, electrical cords that might be in one's way when walking, loose throw rugs or carpets where the corners are turned up a little bit. Just the changes in floor surface when one goes from a carpeted room to a room with bare floor, for example, can pose a fall risk. Furniture that's a little bit wobbly, or cabinets or chairs that are too high, pose hazards in the home, as does poor or inadequate lighting. And you might be surprised to know that pets and pet-related objects actually cause a lot of falls, and that's a common fall hazard. Pet toys and food dishes, things like that.
As a pet owner, it does not come as that much of a surprise to me that that's a hazard. Now, what about supportive features? Are there things that houses can have, or maybe that houses often lack, that contribute to the risk as well?
Well, there are some supportive features, but unfortunately most homes lack certain features that can actually be protective against falls. So some of the most common examples are, most homes lack stair railings, especially on outside stairs. Most homes lack grab bars in the bathroom. It's very rare to find, ramps. And most homes have bathrooms that don't necessarily have, easy access features like walk-in showers or things like that.
Okay. So that's a really comprehensive look at what are the risk factors inside the home and some ideas about things we can modify to make it safer in the home. Let's talk about the environment once you step outside of the home. Where do those risk factors come from, and what do those look like?
Well, we see some of the same risk factors in the outside environment or in the built environment that we see inside the home, such as poor lighting or obstacles in walkways, slippery walking surfaces, commercial buildings that have tile floors that get very slippery when they're wet, for example. But we also commonly see outside, I'm sure you've noticed it, cracked pavement and sidewalks that are uneven. It's pretty typical in an urban environment to see sidewalks where tree roots are, disrupting the sidewalk. Those can all pose fall hazards.
And are there, in addition to those, I would imagine that the cracked sidewalk becomes more dangerous as the conditions change as we move into winter. Are there factors related to that as well?
That's absolutely right, particularly in this part of the country. Snow and ice on walkways or steps is a significant fall hazard for a good proportion of the year. And there's other ways in which commercial buildings are designed or maintained that can pose fall risks, such as the types of building mats that are used or the way door sills are designed. Many commercial buildings lack certain safety features that would reduce the risk of falls, or it's common that there's glare from different types of lighting that can pose a fall risk.
So we've covered a lot of different factors in and outside of the home that contribute to the risk of falling. Why don't we shift gears a little bit now and talk about what do we know about falls prevention? Okay.
Well, we actually know and have a lot of evidence to support this, that there are specific strategies that are quite effective at preventing falls. So that's really a piece of good news. Probably the most important and most effective strategy preventing falls is strength and balance exercises. Exercises that increase lower body strength and that increase balance. Other effective strategies are medication reviews, annual vision exams, and identifying and modifying safety hazards in the home. And not surprisingly, a multifactorial approach is best. So the more that you can incorporate more than one of these strategies, the more effective you'll be at preventing falls.
That certainly makes sense. Now, can you give us some examples or talk about specific examples of falls prevention programs that incorporate one or more of these strategies that you've referenced?
Sure. There are several evidence-based fall prevention programs that are out there that have been shown to reduce falls in randomized controlled trials, and I'm going to highlight 4 of them today. And all you'll see are quite different at meeting the needs of different groups of people, which is very good for attracting different audiences and designing programs that meet different needs. So the first one that I'm going to talk about is a Tai Chi program. Tai Chi Moving for Better Balance, which is a program that was developed at the Oregon Research Institute, and it's based on a large body of evidence that suggests that Tai Chi is a good exercise for improving strength and balance. This program is a simplified version of 8 Tai Chi forms that's designed for older adults who have no Tai Chi experience. It's a 12-week program that involves 2 60-minute group sessions per week plus at-home practice in between. And this program has been shown to be quite effective at leading to fewer falls, fewer injuries from falls, and improved balance and reduced fear of falling. And that's because it's very good at improving leg and core strength and balance. And I know from my experience working with the New York State Department of Health, who's implemented this program in various places in the state, we know that this program seems to be very attractive to older adults. People are very interested in doing Tai Chi and have a lot of fun with it.
That's great, because when they're interested, they're more likely to come, and the more they come, the better it gets.
That's right.
So,
right.
Excellent. I also understand there's a program called Stepping On that you're familiar with.
That's right. Stepping On is also another very popular program, but it's quite different from Tai Chi in that it is a multifactorial program that doesn't just focus on exercise. This was first developed at the University of Sydney in Australia and then modified for use in this country at the University of Wisconsin. And this is a program that incorporates 7 weekly 2-hour sessions. And it focuses not only on improving balance and strength, but also focuses on things like increasing the safety of one's home, vision screening, medication review, and safe footwear. And each session in this program is led by a content expert. So for example, a pharmacist might come in and do the session on medication review. We know that this program is effective at leading to fewer falls and increasing one's confidence about avoiding a fall. And this program seems to be especially effective for older men. And it is effective because it increases self-efficacy and promotes actual behavior change that's important for preventing falls.
Well, that sounds like a wonderful program. Let's take a minute now to hear from a peer leader for the Stepping On program in Suffolk County.
My name is Ron Zola. I'm 66 years old. I'm retired. I worked for Nassau County Department of Public Works for 31 years as a maintenance mechanic. And I've lived on Long Island all my life. Currently, I'm involved as what's known as a peer leader with a fall prevention program called Stepping On. And the function of a peer leader is I'm kind of like a cheerleader, an encourager, and an aid and helper to a trained leader in the program. And I got involved with it because I really think the program is powerful and helpful, and it's changing people's lives, and that motivated me to become involved. The fall prevention course, it's a multifaceted course. And if you had asked me a few years ago about fall prevention in a course, I would have said, well, how can you have a course about that? It seems like you could cover it so easily, There's an exercise program that are given to these seniors that has been research-based and scientifically proven to reduce falls. And what's wonderful about it is it's geared for the seniors. It's something they can do. You don't have to put on special clothing. You don't have to go to a special location. It's not strenuous. And yet the benefit of the exercises is amazing. 4 of them are for aiding the seniors in their balance, to help them balance better, and 4 of them are for strengthening. And so that's at the center. Also, I like the format in which it's done. It's done in a small group setting, generally under 20 people. where the teachers get a chance to know the individuals, and the individuals get a chance to kind of know each other. We encourage them to make friends with each other during these 7 weeks. And that's important. They need to feel that. They need to feel like you're not just doing a job, that you're there because you care about them. And in this youth-oriented society we live in, sometimes the older generation feels pushed aside. They feel left out. They feel like nobody cares. You know, learning, the ability to learn or not learn is not limited to age. It's limited more to personality. And the people, you know, there's a segment of the senior generation out there that is hungry for knowledge, hungry to learn what will benefit them. And when somebody comes along and brings that to them, boy, are they appreciative. Probably one of the biggest benefits I see from this program is a fall prevention awareness. We want to create behavior change with people. That's one of the reasons it's a 7-week course, because people's behavior doesn't change overnight. It usually takes repetition and redundance to change behavior. I like to speak to the group about the importance of not going into denial. Accept the fact that you're getting older. It's okay. We need to have wisdom and make the adjustments so that we can age successfully, and the end of our life can be a wonderful thing. How unfortunate it is when a senior citizen has an unnecessary fall that ruins the quality of their life, or worse yet, even shortens their life. That is so sad. And so this course is all about preventing that type of thing.
Well, what a wonderful program. It's great to hear firsthand from people that are actually involved with it about the work that you've been describing to us. Terrific things that are going on. Also, I understand it's not just the 2 programs you've talked about, but there's more that you'd like to share with us as well.
Yeah, I have examples of a couple other programs
Great.
I can share with you.
Great.
So another one that's starting to get a little bit more recognition right now is called the Otago Exercise Program, and this actually was first developed at the University of Otago in New Zealand. And this is a very different program than the 2 I've previously mentioned, because it's very individualized. It's not a program based around group sessions, but instead it's a year-long program that involves 7 home visits interspersed with 7 phone calls, and it's a very individually designed and individually paced program that focuses on muscle strengthening and balance retraining exercises specifically, as well as it includes a walking plan. So this program is delivered by a physical therapist or a nurse receiving physical therapy supervision. And participants are expected to exercise on their own 3 times a week for about 30 minutes at a time, and walk at least twice a week. And this program has been demonstrated to reduce falls, especially among the oldest those over the age of 85. And it works because it's very good at increasing leg strength and balance.
Excellent. And I think is there one more that you'd like to share with us about, A Matter of Balance?
Yes, Matter of Balance program is also quite different kind of program in that it focuses primarily on reducing the fear of falling. This program was originally developed about over 10 years ago at Boston University, and it emphasizes practical strategies for older adults who have a fear of falling already to learn how to view falls and the fear of falling as controllable. And as a result, it emphasizes practical strategies to increase their activity levels, to be able to exercise despite having a fear of falling, to change their environment, and reduce that fear of falling. It's also a group session class, so it's designed around 8 2-hour small group sessions led by a volunteer lay leader, so a peer, older adult. And people who've participated in this program have demonstrated increased self-efficacy or increased confidence about being able to avoid a fall, have demonstrated increased physical and social activity, and greater mobility control. And that's because this program really focuses on increasing one's self-efficacy for avoiding falls and kind of managing that fear of falling.
It's really wonderful to hear about the different programs and how they each take sort of a different approach to falls prevention, so that it seems like there's really something out there for everyone.
That's right. That's the nice thing about these different programs, is that they're not all the same and they speak to different target audiences.
Great. So there's a lot of information that you've shared with us so far today, if folks wanted to learn more about any of these programs or other fall prevention information, where would they find information?
Well, there's a lot of great resources out there, and I've provided links to a number of them, including the New York State Department of the Bureau of Injury Prevention and Occupational Health, and some other local and national resources. People can go to these websites and find all kinds of things related to just information about the problem, descriptions of these and other programs, as well as toolkits and actual things that can be used to implement some of these fall prevention strategies we've talked about. So I encourage people to utilize these resources because there's some great information out there.
Great. Well, thank you so much. I know just in working with you, I've learned so much more about falls prevention and risks for falls than I knew before we started working together. So thank you for everything you've shared.
Well, thank you. It's been enjoyable.
Wonderful. And now, finally, we'll get to hear from you. Jane, welcome. Thank you for being here. Let's start by talking. I understand you have a lot of experience with community coalitions, and I'd love to hear about how that plays a role in falls prevention.
Sure. In Suffolk County, we have a lot of experience with this in terms of injury prevention, and we started a falls prevention coalition about 3 years ago. And some of the core components of coalitions that are important to have on board are coalitions that are going to have at their center addressing education, enforcement, policy, different levels of change when it comes to injury prevention, because you need all those levels in order to sustain lasting change in a community. It's a group effort, so while it might sound obvious, you know, having a group work on something really gives you 1 + 1 is 3, and you don't have individual organizations working in isolation from each other, and you have people coming together, and it's more coordinated, and you need at the center of it a lead agency. Many times a local health department is a perfect lead agency. They have stature in the community, they have the resources, they have the knowledge about different facets of the community, and they should be the center of the spokes of the wheel, as it were.
Okay, and so what kinds of things does a coalition need to have to be truly effective? I mean, you've touched on some of the things about the benefits of having a coalition, but how do we make a coalition that's actually effective in getting work done?
You need to come to consensus initially. Bring partners around the table who are not necessarily what I call traditional partners. It shouldn't be about us. It should be about the people that you want to target. So like we have one of our partners is AARP. And that might not be a traditional health partner, but it's somebody who is core to being successful. So you want to come to consensus about common goals, so that you don't have a lot of infighting, or you have really everybody's on the same page. You want to be issue oriented. You want to be able to have people who have complementary skills, so that this one has strength in this area, this one has strength in another area. You want to agree on an action plan. So I'm going to do this, you're going to do that, somebody else is going to do the other thing, and this is how we're going to bring it all together and move forward. You have to be open to changes, because change can be very hard for some people. So changes in processes help people within the coalition to implement change in their organizations, so to draw on others' strengths in being able to do that. And there needs to be a commitment to making the group work, otherwise they can fall apart. So those are some core things to help a group become cohesive and move together.
Excellent. And are there other factors as well? That was certainly an extensive list of things that are important, but are there other factors as well?
Well, you want to be sure that you have people from diverse backgrounds, and people who have different areas of knowledge. So somebody might be an expert in health literacy. Someone else might be an expert in we have academics on our coalition. Someone else might be involved in home care. So you want people who have a different area of expertise, and over time the knowledge of all the members is going to increase, so that everybody, even a layperson to the most highly educated academic, are both feeling like they're part of the group, and they have a grasp of the content, and they're sharing decisions. Be respectful about that, about your group process. Organizations should be open to linking with each other, and we have found that they are. You want to have community leadership in different parts of the community, different elements of the community, and to have a positive climate within the organization, so that it's not just what I call the flavor of the month, that it's something that people continue to be committed to, feel there's something in it for them, and want to continue to be a part of.
Sure, that makes sense to me. If it's something that's a positive environment, it's something you want to keep going back to, keep contributing to. So once you've established these elements, you understand what it takes to make an effective coalition. What is the primary role of the coalition? What kinds of things do you do?
Well, the coalition really functions to keep everybody moving forward. You know, we're like a herd moving forward. You know, keep everybody moving forward in the same direction. Sometimes people will have to have a certain agenda for their particular institution. And so we understand and respect that. And so we will help them with doing that, because their institution needs to be, or their organization needs to be committed to this in order for us all as a group to be able to move forward. It improves our capacity to plan and to evaluate things. You've got different resources at the table. And it enhances the capacity of local leaders and organizations to educate the community. And a successful coalition really garners the commitment and the buy-in of leaders. So policy leaders, elected officials, leaders within communities, organizations, you need that buy-in in order to influence things at an individual and a local and family level, to be sustaining with that kind of change.
Sure. Now, I understand that in Suffolk County where you work, you have a coalition, is that correct?
Yes, we started as part of our community health assessment process, and we picked 2 areas that we wanted to focus on in terms of moving forward, and one of them was falls prevention. Mm-hmm. And so we brought together some partners that might have seemed unlikely to sit at a table over, we've been functioning now for 3 years. So we have, in our county's very large, it's 1.5 million people, which is larger than many states, 13 states to be exact. So we have 11 hospitals, and we have at the table 7 of those hospitals coming on a regular basis. So they're obviously getting something out of this. And we have, obviously the health department has made a significant commitment with staff resources to this. We have AARP, we have a pharmacist who's on faculty at a university, we have a geriatric internist, a physician who comes to every meeting, our Office for Aging, we have biostatistical resources, we have several area colleges and universities, because we have a student component to this, where we have students in our nursing schools and PT schools who are doing, as part of their clinical placement, falls prevention activities, and we have home care agencies. So there's a broad array of expertise and partners.
So with that many different folks, with that broad array, what's the common goal? What is your coalition working towards?
The coalition is really working towards implementing falls prevention practices in different areas of our county. So the New York State Health Department has selected us, our local health department, for a small grant, but it helps to drive commitment and policy to implement Tai Chi, stepping on, another course we're doing called Staying Independent for Life, which is a local 2-hour session, because we had so much demand for stepping on that we couldn't meet. We've had several summits about falls. We've developed a communications plan, and we're working on doing some. We're even working now on looking at next September, which is Falls Prevention Awareness Month, so that we can, really be doing something that's meaningful and that's thought through and thinking ahead about this. We also got the commitment of our commissioner in our county to assign a falls prevention coordinator within the health department, and that's you saw her in the clip. And she's a stepping on leader, and it helps to center the program, to anchor it, to have someone who does this as their function. That really helps to propel something forward and demonstrates a commitment. As a matter of fact, we're now assigning someone else because we have such a high demand. We've educated in Stepping On and our Staying Independent for Life. We've educated over 2,000 people in the past 2 years. It's huge. The demand it's like we opened up a door and there was like all these gifts inside. It's really just the groundswell of support has been tremendous. So our commissioner has committed for us to have additional staff doing this as well.
That's really exciting to hear about what demand there is for that, and how many folks you've gotten to come together and to take advantage of the services you offer. Now, one of the things that we had talked about, you and I, is the importance of how you communicate with folks. And so you've got all of these invested people and folks who there is the demand for the programs, but how do we most effectively get the message out there about all of these people who want to offer their services and who want to contribute to falls prevention?
You know, we want to be able to, sometimes as a health professional, I've been a nurse for 35 years, you know, we think, well, we're the professionals and we know what people ought to know and we know what the content we're going to present, but we really have to get outside of ourselves and think about what's an effective way for somebody to be able to hear what we're saying, to learn, and to be able to change their behavior. And that's a little different. I was talking actually to the cab driver this morning on my way over here, and I told him I'm going to, you know, this broadcast, and he was telling me about people he gives cab rides to and saying that they're really interested in staying independent. And I thought, well, how insightful, because that's really one of the focuses of successful aging is staying independent. So we want to think about adult learning principles, successful aging, what people want to know about literacy issues, health literacy, cognitive issues, how to design interventions that are going to be successful, and to look at people learning things as opposed to people changing their behavior. Those are two separate things. Mm-hmm. Just because they learn something doesn't mean they're going to change their behavior. So we want to address both of those areas.
Absolutely. So you mentioned adult learning principles. Talk to us a little bit about ways to communicate to adults that will be both respectful of the adult and something that they understand, something that's meaningful to them.
Well, one thing that our mature adults, they prefer to be called mature adults in our focus groups, have talked about is their wisdom, and that they want to learn, move ahead from a base of knowledge that they already have. So people will learn best in response to what they perceive as a need. So we want to frame falls within how people can improve their lives. They want to progress from the known to the unknown, so they don't feel like a fish out of water right at the outset. People want to, you want to progress from simple to more complex concepts, so people feel capable and competent with what they're learning, and they're more likely to be engaged with the whole process. Mm-hmm. Instead of feeling like, you know, where have I arrived? I don't understand what you're talking about. Mm-hmm. So those are some of the key things. Move from something simple like home modification. People would have more of a baseline of knowledge about, and then move to medications, which can be more complex, sure. Exercises, Tai Chi. So that type of progression
makes sense.
is very important in terms of people learning.
Sure. And also in terms of the adult learning principles, does it make a difference the style of whether I'm kind of sitting passively and learning versus you really actively engaging me and drawing information out?
Absolutely. Active participation is key to successful learning. Just like when I met you and we've talked about falls and you've asked questions and we've talked, you know, you learn more than just a didactic setting. You want to make sure that you're grounded in terms of what people are understanding. So you want to say to them, tell me about such and such, what you learned, instead of do you understand? And you know, you don't want just a yes/no answer. You want that type of feedback. That people learn when there's opportunities to practice skill during a session. In our Staying Independent for Life program, initially we didn't have exercise as part of it, and we evaluated it, and the participants told us that they wanted exercises and they wanted to be able to practice them. So, and also that kind of feedback. Evaluation is very important. You want to reinforce positive behavior. And provide immediate feedback. So if somebody's doing an exercise improperly, you want to be able to tell them, no, try this instead. That'll make a difference, and reinforce whatever skills they're learning.
Sure. Now, how do those different principles in getting folks engaged and giving them an opportunity to practice all sound like great ways to help them successfully learn and change behaviors? What do perceptions have to do with this? How does this relate to someone's perception of either the risk of falling or their fears and things of that nature?
Well, perceptions are key because some people, let's say if they perceive that falling is inevitable, then they may not be thinking that they can do anything to make a difference. So you want to address that and not just ignore it because it's real for them. So you want to address what people have in terms of perceptions about themselves, what they perceive as being important to them, how threatening a health problem appears to them, because that's key. I'll talk about that in a bit. That's key to a formula for success, or to developing a formula for success. And you want to think about people's perceived ability to be able to respond to a threat. You know, if people don't think they can do anything about something, they're not going to bother.
Mm-hmm. So when, in the work that you've done, in your experience, are falls, is that something that most adults have given thought to, have most considered these things?
Most 90% of older adults have given serious thought to aging and aging successfully. And they've identified attributes that are important to aging successfully. You heard Ron on the tape talk about some of those components.
Mm-hmm.
So people want to stay healthy until they're near death. They want to stay involved with the world. They want to be able to make choices that affect their aging. They want to be able to feel good about themselves, to be able to take care of themselves, to cope with the challenges of aging, to stay free of chronic health problems. So those are some of the things, that's how they're thinking. And we need to focus our messaging and our communication around that, and not just around what we think might be an important message, because that's what they're going to hear.
Mm-hmm.
You know, you heard Ron was talking about how they want to be respected for their wisdom. And those types of things are very, and I heard that in focus groups that I've done that Ron was not part of, and those types of things are key to engaging and motivating people.
Absolutely, and all of that seems to make sense. So what about some of the perceptions and beliefs that older adults have about falls prevention program? Let's talk more specifically about that.
Well, you know, we want to know, they want to know that this is relevant to their lives. They may deny risks, so that can be a barrier that you need to think about. And there may be poor self-efficacy, and what that means in normal language is self-efficacy is feeling that you have the ability to take control and to make a change that's going to make a difference, that you're not just afraid of something that's very threatening to you, that you can take steps that will make a difference. So you want to involve that in your strategy. The intervention should be lifestyle enhancing, and a big feature of your interventions should focus around staying independent.
Because that does seem to be a key concern that we've heard over and over again, is remaining independent is the goal.
Yes, even the cab driver talked about that.
And if the cab driver's talking about it, then it must be a hot topic.
It's out there. It's out there in the world.
Sure. So let's talk about the role that fear plays in all of this and the messaging that you do.
Well, fear arousal. You know, people can tend to want to make someone change. You know, adult children of older adults say, you know, Mom, you're going to end up in the nursing home. You got to do this, that, and the other thing. That type of fear arousal can tend to turn people away from the message and precipitate denial of a message. So it's a response to a threat that arouses fear related to some decision that people are thinking that they can't do anything about this. So people will fear losing their home, they'll fear losing their independence, and this can drive them to not tell anyone that they even fall, because they're afraid of losing their independence. They're afraid they're going to be yanked. Come on, okay, Mom, it's time for you to, you know, give up the house and come live with us. They're afraid of that, so they don't want to talk about it.
So in contrast, if the message focuses on self-efficacy, let's talk a little bit about how folks respond to that.
So that is really the key. You can have some fear arousal message, but that should not be overriding. But self-efficacy, feeling that you can do something. That's why stepping on is so successful, because you have people, the participants in stepping on are talking with each other and developing strategies and using the strengths and the wisdom of the group to drive change.
Sure.
So self-efficacy will promote avoidance of fear. You don't have the denial. People don't think this is too scary to think about, and they don't think that others are just being manipulative or just trying to dismiss whatever fears they might have.
Sure, that makes sense. Now, in most cases, I would imagine people have good intentions, no matter whether they're bringing it up from a fear perspective or self-efficacy. They have a good intention of trying to address the problem. But let's talk about the outcomes, regardless of what your intention are.
So when you balance fear threats versus self-efficacy wins, because people are feeling that they can take control and do something that's positive and productive, even if you start at with small steps.
Sure.
They feel they can do something that's meaningful.
Great. Now, what about health literacy? Does that play a factor in fall risk of having falls?
Well, you know, the older adults over the age of 65 have a disproportionate level of low health literacy as compared to the rest of the population, and many people don't know that. So some of the risk factors for poor health literacy or low health literacy are if somebody's an immigrant and English is not their native language, particularly if they didn't have a high level of education in their native country, people who are not high school graduates, but it's not just about formal education. People who are ethnic minorities, because some of the other risk factors go along with that. Mm-hmm. People with physical, mental, or health conditions, visual problems, and people age 65 and older. So when you think about the elderly, they may have visual problems, other health problems, and cognitive issues. So there are things going on that put them at risk for not having high levels of health literacy.
Interesting. I was not aware of that myself. So let's talk about literacy levels and how they vary by age.
So, excuse me. So literacy over the age range, it has four ranges: below basic, basic, intermediate, and proficient. And you really worry about below basic and basic levels. So in the younger people, the below basic and basic represents about 33% of that population up to about age 64. When you look at age 65 and over, it's about half of them who have low levels, basic and below basic levels of health literacy. And that's a significant problem because we tend to give out materials that are very high level, and sometimes they're not meaningful for our target population, particularly with older adults.
Sure, and that information surprised me, so that's great to share with folks that is an issue that we might want to consider. Now, what are some of the things that go into when we look at older adults have some higher percentages of lower literacy? Talk to us a little bit about why that is.
Well, there have been some large prospective studies done on older adults that have looked at their levels of literacy over time. So you might think that they're more at risk because maybe they didn't finish high school. But that's not the case. You know, literacy is not just about reading and reading words. You also have to be able to have adequate concentration, vision, word recognition. You have to be able to connect a word that you read here with a word that you read, 2 pages ago. As I like to say, I can't even remember what I had for breakfast. So you have to be able to connect things in text and within the context of whatever it is you're trying to learn. And you have to have a good working memory. So that's some of the reasons why, as people get older, their literacy levels go down. And it includes components like listening, speaking, and conceptual knowledge. And I think it's really under-recognized when we deal with older adults because we think about them just being an older version of who they were when they were 30.
Sure.
But there are these other changes that are significantly impacting literacy.
Sure. So those are the different factors that go into the lower literacy rates. Tell us a little bit about the impact of having those lower literacy rates.
Well, health literacy, which has been the area of health literacy and health outcomes has been studied more and more extensively over the past several decades, and it's felt that it's maybe one pathway that explains the link between education and health. That it's really very meaningful in terms of health outcomes. It results in a decreased ability to share in decision making, lower adherence to treatment, and much higher healthcare costs and other costs that spill out as a result of that.
So certainly an important thing to consider. Now, I also understand, shifting gears a little bit, that you've done some focus groups with older adults, and what are the messages they want to hear? What are the most effective ways to communicate with them? Can you talk a little bit about those focus groups?
Sure. Doing focus groups was being very experienced nurse and public health professional. It was a very humbling experience for me, but very, very meaningful and valuable. What the group told me was that they didn't want to know about falls because it scared them. That it made them feel old, and if they were in the doctor's office, they would not pick up a brochure that said, "Here's how to prevent falls." They didn't want to hear about it. They wanted to know about what we identified earlier as feeling good, staying healthy, components of successful aging. They did not want messages to involve their adult children, or have messages say to them that they should tell their adult children if they had fallen. And they thought that the healthcare providers that they saw were young and were not experienced like they were, and didn't place all that much value in some of the messages they were getting from their healthcare providers. It was very meaningful.
Yeah, that's some really interesting information that you got, good feedback. Now, one of the things that you said that stood out to me was that they said they would not be likely to pick up a brochure, and I know that your county has brochures, so talk to us a little bit about what you did to design a brochure that would be appealing or appropriate for adults.
Our group, and it was actually a coalition member who offered retired senior volunteers to do the focus group with us, and our coalition was involved in this, and we developed educational materials that, as I like to say, the focus group chewed them up and spit them out, and told us what was wrong and told us what was right, and we went through several drafts, and so we came up with this brochure called "Staying Independent for Life." They picked that title, and they wanted someone healthy on the front cover who was doing something active. So we tested it to see, just because we think it's great doesn't mean that it has meaning to anyone. So we tested to look and see whether people learned and whether they intended to change their behavior. And we found that before they read the materials, only 16% knew about falls prevention, and that jumped up to 40%. That's highly significant. Mm-hmm. And that the intention to change their behavior jumped from similar levels, about 14% to about 38%. So we've made this brochure available not only to the general community, but also our partners in our coalition.
Great.
If they want to take it back to their hospital or their community organization and have their logo on it and our logo on it, they can do that.
Make things happen.
So that because they
together,
need to,
sure.
Bring something back.
Sure.
So it's really working out very, very well.
Excellent. So with all of the things you've shared, what are some recommendations that you would make as we move forward and try to advance falls prevention? What would you recommend?
I think coalitions are key. You get more, as I call it, bang for the buck. And you get people around the table who all can offer something really valuable and complementary. I think linking people who are at risk with community-based programs, getting the word out there in places that we do, like assisted living places and libraries and senior centers. I think that type of linkage is important. We're planning on working in the State Health Department. We're part of their grant, and we're looking to do screening within primary care settings that are very short and sweet and effective, so it doesn't take a lot of time out of clinical care. And you need to focus beyond home hazards. I mean, I thought for many years that it was about scatter rugs, and it's not. It's really more about the person. So to have those components built in will make for a successful program.
Excellent. Well, thank you both very much. We have just a little bit of time for some of the questions that came in from the audience. The first, I think, is pretty simple. Is there somewhere to find out about the program, such as Stepping On, in our area? Is there a website?
Well, I can point to a couple of resources that were listed on that resources slide.
Okay.
First of all, some overall information about Stepping On is available from the CDC, the Centers for Disease Control and Prevention. In fact, on their website, they put together a couple years ago a document called a Compendium of Falls Prevention Programs that highlights and gives a brief overview and where to go for more information. a number of evidence-based fall prevention programs, including most of the ones I talked about today and a number of others, and that includes Stepping On.
Great.
But also the New York State Department of Health, the Bureau of Injury Prevention and Occupational Health, they have a grant right now, and they are, as part of that project, implementing Stepping On in a number of counties, Suffolk County being one of them. And so that would be a great resource also to find out about what's going on in the state.
There are 5 communities across the country that the CDC has funded. 3 are in New York State, done through the New York State Department of Health, and then Denver and Portland.
So it is in other states as well. I believe
Yes.
this question actually came in from out of state, so the CDC would be a good place to go for information.
Good starting place, yep.
They've been
Excellent.
very supportive, and they have a
Excellent.
lot of expertise in this area.
Great. Now, Jane, question for you. What outreach efforts would you suggest to increase participation of community-based and other locally based organizations?
I think that people have to feel that there's something in it for them, having worked with community groups for many years. So I think that instead of going and saying, we have X package to offer you, I think going and finding out from community groups and going to places where people naturally go, the target population, and finding out what they need, and then incorporating what you want to do into what it is that people feel that they need, I think it's the most meaningful way to, because I think the people are really talking about how do you engage people. So finding out what they need and trying to engage them at that level.
And the last question that I think we'll have time for is that the statistics on literacy for individuals over age 64 didn't show up on the slide. Would you be willing to repeat those again? And those are also, the handouts are available on our website, so folks can certainly print it out there.
Yes, and the font was, the font was, we'll change the font to a different color. Literacy, the lower literacy levels for older adults are about 60% have below basic and basic levels of literacy, which is striking when you compare that to the younger ages, which is about maybe a third, which is bad enough, but it's striking.
Well, thank you both very much. I think that's all the questions we have time for today, and thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nursing continuing education, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming broadcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help further your knowledge and understanding of topics covered in today's program. An archive of this webcast will be available on our website within 2 weeks, and please join us for our next broadcast on January 17th, Sugary Beverages, Why the Fuss and What You Can Do About It. I'm Rachel Breitster. Thanks for joining us on Public Health Live.